Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the channel of Stand Medical Notes. Let us learn today about the second acute complication of type 2 diabetes mellitus in particular. Okay, so let's begin with the name of Almighty. So the second complication is hyperosmolar hyperglycemic state. So the key criteria for diagnosis lies in definition only. So the osmolality is increased, glucose levels are increased, but there is no acidosis, and there is no ketonemia. So by definition only we will have the diagnostic criteria. Okay, similarly in DK, so D means diabetes, that is nothing but increased glucose. K means keto, that is nothing but presence of ketonemia. A means acidosis, that is nothing but presence of acidosis. So if these three are present, then it is diabetic ketoacidosis. And in hyperosmolar hyperglycemic state, hyperosmolar meaning osmolality is increased, hyperglycemia there is increased blood sugar levels, but there is no acidosis and no ketonemia. Okay, that is a state known as hyperosmolar hyperglycemic state. Okay, so first concept, definition and overview. Coming to first the concept and definition. So HHS is an insidious severe metabolic complication of type 2 diabetes mellitus. HHS is an insidious, remember, diabetic ketoacidosis, it is an acute complication, whereas HHS is an insidious complication of type 2 diabetes mellitus in particular. Severe metabolic complication of type 2 diabetes characterized by hyperglycemia, profound extracellular hyperosmolality and associated severe dehydration. So you will not have any ketoacidosis here, meaning there will be no ketonemia and there will be no acidosis. So this is primarily seen in type 2 diabetes mellitus. So this is a flow chart, overview flow chart. Okay, just see key pathology. There is relative insulin deficiency, insufficient insulin action, not absolute deficiency. So that relative insulin deficiency is able to suppress the lipolysis, but not able to suppress the hyperglycemia. So that is the thing which happens in diabetic ketosis. That's why there is no lipolysis, so there is no free fatty acids, there is no ketonemia, there is no acidosis. So insulin levels will be at a level that suppresses the lipolysis but will not suppress the hyperglycemia. So that is the thing, key difference in pathophysiology. Okay, so insulin action is insufficient insulin action, not absolute insulin deficiency. That's why there is decreased glucose utilization that will cause extreme hyperglycemia and markedly elevated blood glucose, often more than 600 milligram per deciliter. That causes osmotic diuresis and fluid loss, glucose drags water and electrolytes in urines, that causes severe dehydration, profound extracellular hyperosmolality, sodium and glucose increase the plasma osmolality. So sodium which is present, so because there is dehydration, there is increased concentration of sodium and increased concentration of glucose. These sodium and glucose will increase the plasma osmolality. Okay, so more than 320 milliosmol per kg. Minimal or no ketosis. Some insulin activity prevents significant ketone body formation. Okay, end result, there will be severe dehydration, hyperosmolality, hyperglycemia without any significant ketoacidosis. So typically the patient profile is a usual elderly patient more than 60 years of age with multiple comorbidities like hypertension, cardiovascular disease, chronic kidney disease, infections, etc., who have a long standing type 2 diabetes and may present with altered maintenance status due to hyperosmolality and It is a reality and it is a recognized feature of this HHS that most of these patients present with CNS dysfunction only. The presentation itself is CNS dysfunction, not like diabetic ketosis, which will progress from symptoms of hyperglycemia to nausea, vomiting, acute abdomen, then altered sensorium, then to coma. Not like that. These patients present directly with CNS dysfunction. Okay. So the precipitating factors include infections, myocardial infarction, stroke, medications, poor intake, and dehydration. These are the precipitating factors. Okay. Infections, MI, stroke, medications which include diuretics, steroids, poor intake, and dehydration. Classical lab profile: plasma glucose will be typically more than 600 mg per deciliter. Effective serum osmolality will be more than 320 milliosmol per kg. pH will be 7.3. Bicarbonate will be more than 18. That means there is no acidosis. Ketones will be none to trace. Serum sodium will be increased. See, corrected for glucose. So sodium should be corrected for. It should be corrected for glucose. So that will be often more than 145 milli equivalents per liter. Whereas in diabetic ketoacidosis, it will be usually because of dilutional hyponatremia, the osmolality will be decreased less than 135. But it is opposite in HHS. It will be often more than 145 milliequivalents per liter, corrected for glucose. You know the formula of correction. Okay. That is nothing but sodium concentration in milliequivalent per liter plus 1.6 under the bracket glucose concentration milligram per deciliter minus 100 divided by 100, which is already discussed in the topic of DKA. Burn by creatinine ratio is elevated. That means there is pre-renal azotemia because of dehydration. Okay, pre-renal azotemia. Okay, so burn by creatinine ratio is elevated. Hematocrit is elevated because of hemoconcentration. The sodium concentration is increasing, and there is ischemia to the kidneys, less blood supply to the kidneys. RBC concentration is increased, glucose concentration is increased. Because of this, all these components concentrations is increasing, there is profound hyperglycemia and hyperosmolality. Osmolality you can think of as concentration only. You can't call it actually as concentration, but it is concentration only. So hyperosmolality of blood means concentration in the blood is increased because of these components. Okay, so profound hyperglycemia, hyperosmolality along with dehydration in the absence of significant ketoacidosis, but there will be no ketoacidosis. So sodium concentration is increased, glucose concentration is increased, hematocrit is also increased. Classical lab profile: severity and outcomes. Mortality rates are very high in this HHS. 15 to 20%, meaning in 100 patients, 15 to 20% of the patients die due to HHS, which is substantially higher than in DKA. Reflects the extreme severity of the metabolic derangement, also reflects the advanced age and complex comorbidities of the typical patient population. So why the mortality is high? This is because of two reasons: because of extreme severity of the metabolic derangement. Second is because this usually occurs in elderly individuals who already have comorbidities. That's why the mortality rate is high. So take home message, one line message of our this overview of this: HHS is a life-threatening emergency of extreme hyperglycemia and hyperosmolality with severe dehydration, occurring mainly in older patients with type 2 diabetes and comorbidities, and requires prompt recognition and aggressive management. So that was about the overview of HHS. Now coming to the pathophysiology of HHS. Okay. So there is severely diminished but non-zero endogenous insulin reserve, severely reduced beta cell reserve. So effect of residual insulin: suppresses the hormone sensitive lipase in adipose tissue, prevents massive lipolysis. That So the some amount of insulin is there, that amount of insulin will suppress the lipolysis. It will suppress the lipase enzyme. That's why lipolysis is suppressed, which will prevent the ketosis. Okay, but that amount of insulin is insufficient to overcome the hyperglycemia. Counter regulatory hormone excess, like during stress, illness, infection, medications, etc., block peripheral glucose utilization. So decreased insulin hormone and increased counter regulatory hormone due to these factors like stress, illness, infection, medications leads to decreased peripheral glucose utilization. Okay, that will result in extreme hyperglycemia, very high plasma glucose, typically more than 600 to 1000 milligram per deciliter. Oh, okay, very high. That will cause hyperglycemia, will cause osmotic diuresis in kidneys. So glucose in renal tubules drags water and electrolytes into urine, causes massive fluid loss. And now one thing is, patient will also have impaired thirst mechanism also. So hyperosmolar state impairs the thirst response, especially in elderly or altered mental status. So that causes inadequate fluid replacement. So in these elderly individuals, so even though the dehydration is occurring, but because the thirst mechanism is not good in these individuals, they are not able to replenish that dehydrated amount of fluid by intake of water because of thirst mechanism. So that is also an important point here. Okay, that causes severe fluid deficit. Up to 8 to 12 liters of water is lost, which is very high. So that accounts for 10 to 15% of total body weight. So that much amount of water is lost, 8 to 12 liters. Okay, so that will result in a vicious cycle. Extreme volume contraction will happen. Okay, that causes decreased renal perfusion, impaired glucose excretion, and impaired glucose excretion will cause worsening hyperglycemia, and that will cause increased hyperosmolality and hyperviscosity. Again, this increased hyperosmolality and hyperviscosity will cause volume contraction and decreased renal perfusion, then impaired glucose excretion, worsening hyperglycemia. So this will result in a vicious, like this, vicious cycle. Okay, clinical consequence of that: progressive dehydration, neurological impairment, multi-organ dysfunction, and high mortality if not treated promptly. So that's about the pathophysiology. Coming to classification and severity, the diagnostic criteria. HHS is defined by biochemical parameters indicating profound hypertonicity rather than acidemia. So you measure usually osmolality, concentration, tonicity of the blood here. Okay, so plasma glucose is typically more than 600 milligram per deciliter. Serum osmolality more than 320 milliosmoles per kg. But arterial pH is more than 7.3, which is normal, and bicarbonate will be more than 18, which is also normal. Ketonemia will be absent to minimal. Okay, mild starvation ketosis may be present. So main thing is increased serum osmolality. So it is in the definition only. So definition defines the criteria for diagnosis. Okay, coming to clinical features, key signs and must not miss diagnosis. Okay, HSS develops insidiously, slowly, okay, over days to weeks, unlike diabetic ketoacidosis, which has rapid onset within 24 hours. Key signs are because of, again, hypovolemia and dehydration similar to decay. So sunken eyes, dry mucous membranes, longitudinal furrows on the tongue, poor skin turgor, resting tachycardia, hypotension, extreme lethargy, and global weakness. So profound hypovolemia and decreased perfusion and cellular dehydration. So you will have signs of dehydration. Okay, signs of dehydration and signs of dehydration along with neurological manifestations. CNS is highly vulnerable to intracellular dehydration, which is a hallmark of HSS. So there is a lot of cellular dehydration, severe cellular dehydration, because of which our brain cells get dehydrated and there will be immediate development of neurological manifestations in this patient. So progressive obtundation and decreased consciousness, delirium and confusion, focal neurological deficits. The patient can also present with focal neurological deficits which can mimic stroke, acute stroke. You need to differentiate with stroke. You need to have a CT scan if the patient has focal neurological deficits to differentiate it from stroke. Hemisensory loss or aphasia, not able to talk. Okay, and even patient can have seizures. That seizures can be focal or generalized. So these are the neurological manifestations, and these patients present usually with neurological manifestations, unlike DKA which progresses from symptoms of hyperglycemia to neurological manifestation. Okay, so decreased consciousness, delirium and confusion, focal neurological deficits which should be differentiated from a stroke by CT scan, and seizures again should be differentiated from any genetic epilepsy. Okay, now moving on forwards. Sorry. Differential diagnosis. Coming to differential diagnosis, from what we should differentiate. So several conditions can mimic the presentation of hyperosmolar hyperglycemic state. Key distinctions are essential for appropriate management. So we first of all we should differentiate from DKA. So as you know, there will be no acidemia, there will be no ketonemia, and anion gap will be wide. So mixed DKA, and one important point to remember is mixed DKA and HHS presentations can also occur. This is also an important point, meaning you can have increased osmolality along with ketonemia and acidosis also. Those presentations are also seen. Okay. Now if the patient has focal neurological deficits, then you need to differentiate from acute ischemic stroke. Distinguishing features: focal neurological deficits in HHS can perfectly mimic acute stroke. However, these deficits frequently resolve completely with the normalization of serum osmolality, but still you need to differentiate with the CT scan, urgent CT scan, because these patients are also prone for thrombotic events because of hypercoagulability of blood. That's why you need to differentiate by CT scan. Third thing is you need to differentiate from uremic encephalopathy. So uremic encephalopathy because of CKD, patients may have CKD. So one need to differentiate uremic encephalopathy. So this may coexist due to severe pre-renal acute kidney injury from extreme dehydration. So seeing the creatinine levels, you will be able to differentiate. Okay, one is uremic encephalopathy, that is one thing. Fourth is sepsis associated development, meaning some infection. So as all of us know that any infection, severe infection, can cause altered sensorium, delirium, febrile delirium. So any infection related delirium, any infection related neurological manifestation, so you should exclude sepsis in these patients, must be excluded via appropriate infectious and toxicological screening. Okay, one more thing is toxins you should exclude. So 4 important points. So number 1 is DKA, and mixed presentations are also possible, and number 2 is acute ischemic stroke, infection associated CNS malfunctioning, and uremic encephalopathy, meaning kidney associated CNS malfunctioning. And one more thing is toxins you should also include. A thorough history, focused examination, and targeted investigations are important to differentiate these conditions and identify the underlying cause of HHS. 4 things you should differentiate. Okay, 4 things. Okay, so there in diabetic ketoacidosis, you need to differentiate from all those causes which cause metabolic acidosis, So HHS also, what are the causes of metabolic acidosis? So this one mainly alcoholic ketoacidosis, starvation ketosis, and sepsis related or metformin associated lactic acidosis, toxin meaning like methanol or polyethylene glycol associated acidosis. So all these 4 things we need to differentiate. Here also 4 things: DKA, acute ischemic stroke, uremic and sepsis. Okay. Now how to diagnose? Diagnostic, what should be our diagnostic approach? How should we diagnose? What should be the diagnosis? And this will be the last thing of this video. Initial laboratory evaluation, obtain baseline labs to evaluate metabolic status and look for precipitants. So blood glucose will measure, electrolytes will measure, burn by creatinine ratio you will measure, ABG and VBG you will do to exclude significant acidosis, and search for underlying trigger finally. It can be infection or infarction or iatrogenic medication. Okay, infection, same thing, same 4 I's of decay. Infection, infarction, there one thing was insulin omission. Okay, here also it can be a cause, insulin omission and iatrogenic or intoxication. So these are 4 I's, same 4 I's applies here also. Okay, now after obtaining these baseline investigations, calculate the effective osmolality, which is central to the diagnosis and management of HHS. How do you calculate? By this formula: 2 into sodium concentration in milliequivalent per liter plus glucose concentration in milligram per deciliter divided by 18. The result you will get is milliosmol per kg. So diagnostic criterion is the osmolality should be more than 320 milliosmol per kg. Milliosmol. For example, some patient is having sodium concentration of 150, okay, plus glucose concentration of you can take it as 500. No, you take glucose concentration of 3672, okay, 720 divided by 18. Okay, this is sodium concentration, this is glucose concentration in milligram percentage, and this is in milliequivalents. So 2 into 150 is actually 300 plus 16 4 za 40, 40 za is 720, so 40, 300 plus 40 is nothing but 340, so which is more than 320. That means the patient is in hyperosmolar state. So this is an example just to calculate. Okay, 2 into sodium concentration in milliequivalent per liter plus glucose concentration in milligram per deciliter divided by 18. Okay, now next thing is we are calculating burn here, blood urea nitrogen. Why burn is excluded? Urea burn is an ineffective osmolar, so burn is excluded here. Okay, blood urea nitrogen is excluded because it is an ineffective osmol, meaning it will not raise the concentration of blood. That's why it is excluded. Urea freely crosses cell membranes. Why it is ineffective osmol? Because of all these reasons. It freely crosses the cell membrane, does not create significant osmotic gradients between blood and brain cells, does not cause rapid water shifts into brain cells. Therefore, burn or urea is excluded from effective osmolality calculations. Okay, you will not find urea in calculation of osmolality. Now, the second thing is calculation of corrected sodium. So, corrected sodium formula already we have learned. What is that sodium formula? So, sodium concentration plus 1.6 into in bracket glucose concentration in milligram per deciliter minus 100 divided by 100. So that gives the corrected sodium. Okay, that gives the corrected. So this is the corrected sodium concentration formula, which is already discussed in the topic of diabetic ketoacidosis. Severe hyperglycemia artificially lowers measured serum sodium. That's why corrected sodium should be concentration should be used. Hyperglycemia pulls water from cells into the plasma. Plasma becomes dilute. Again, here also there is dilutional hyponatremia. Measured sodium appears falsely low because of dilutional hyponatremia. What to do? Calculate corrected sodium. Use standard correction formula. Repeat serially during treatment. Accurately assess true sodium status, water deficit, changes during food therapy. Okay, so first what you are doing? Baseline investigations we are calculating. Then we are calculating from that investigations osmolality, then sodium, osmolality and sodium, osmolality and corrected sodium, osmolality and corrected sodium. Then we are confirming the HHS. Diagnosis is based on biochemical criteria of hypertonicity and not acidemia. Plasma glucose should be more than 600. Effective serum osmolality should be more than 320. Arterial pH should be more than 7.3. Serum biochemical should be more than 18. And ketonemia should be absent. No significant acidemia. So if patient meets all these criteria, then HHS is diagnosed. The pathological series in HHS: severe hyperglycemia, water shifts from plasma, dilutional hyponatremia, so sodium needs correction, calculate effective osmolality, assess severity of brain dehydration, diagnose and monitor HHS. One point to remember is DK and HHS mixed presentation is possible. This point to remember. And one more point here is one clinical pearl. In HHS, the most important number after glucose is the effective serum osmolality. Okay, because neurological dysfunction correlates closely with the degree of hyperosmolality. That means the more the osmolality, the more the malfunctioning of CNS. The more the malfunctioning of CNS. Okay, I think this is enough for today. We will discuss in the next class. Thank you.